Good morning, everyone, and welcome to Palliative Care Chalk Talks. My name is Kristen. I'm a hospice chaplain at LA Home and Hospice in Brookfield, and I have the privilege to moderate a wonderful talk today by Corinne Kramer. Corinne is a psychotherapist at Ascension with a background in medical social work. She's worked in oncology, hospice, and palliative care, but she's also done substantial work in behavioral health for 23 years. And so I am excited to hand it off to Corinne. She'll be presenting for about 20 minutes, and then we will have a time of Q&A where you can either unmute yourself or ask your question in the chat box. Thanks, Corinne.
Thank you, Kristen. I'm Corinne Kramer. I'm going to be talking about behavioral health within palliative care. Far too many diagnoses to talk about in one session. So decided to break it up into different topics. Today was going to start with behavioral health within palliative care, part 1, personality disorders. So a vast body of research shows that many people living with serious medical illness like cancer, heart disease, COPD, etc., also suffer from comorbid behavioral health issues. These can be pre-existing issues, exacerbation of pre-existing issues, de novo, which could include adjustment disorders, responses to financial and role changes, stress, medication-related mood or psychotic symptoms, or cognitive impairment. So what is palliative care? Palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. I did bold emotional symptoms, depression, and anxiety to show that there's a lot of overlap with behavioral health within palliative care. It's kind of right in the job description to help with these anxiety, depression, emotional symptoms. So we know what palliative care is. What is a personality disorder? So a personality disorder, it's an enduring pattern of inner experience and behavior that deviates markedly from the expectation of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. So within a personality, we may all have certain traits. People might say, wow, they're a little narcissistic, or wow, how histrionic. We have traits, that's a personality. But it's when these traits are to the point where they lead to distress or impairment and have specific diagnostic criteria, it is when they meet a personality disorder. So what's the general diagnostic features? Personality traits are enduring patterns of perceiving, relating to, and thinking about the environment and oneself that are exhibited in a wide range of social and personal contexts. Only when personality traits are inflexible and maladaptive and cause significant functional impairment or subjective distress do they constitute personality disorders. Next. So according to the DSM-5, there are 10 different personality disorders. There is a little section in the DSM-5 that talks about, there's one more section where if it doesn't meet this criteria and it's due to medical reasons, but there's 10 concrete personality disorders in the DSM-5. So these personality disorders are in 3 different clusters, A, B, and C. The first, cluster A, disorders are characterized by odd or eccentric patterns of thinking, such as extreme social detachment, distrust, or unusual beliefs. And these include paranoid personality disorder, schizoid personality disorder, and schizotypical personality disorder. Cluster B disorders feature unstable emotional states and erratic behavior, which can involve aggression toward or manipulation of others. And these include antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Cluster C disorders involve anxious or fearful patterns of thinking and relating to others. These include avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorders. So it is estimated that 10% to 13% of the world's population suffer from some form of personality disorder. So if you look around you, or if you're with your patients, 1 to or 10 to 13%. So something to keep in mind. I will add, I don't have this on here. The most researched personality disorder is borderline personality disorder. And the most common personality disorder is obsessive compulsive personality disorder. So personality disorders are notoriously hard to treat. If anyone remembers the axis, it's axis 2, which means that it's pervasive over time, and it's very hard to treat. But research suggests that DBT therapy, dialectical behavioral therapy, and cognitive behavioral therapy can help people with one of the most common disorders, which is borderline personality disorder. Treatment may vary depending on the particular personality disorder, its severity, and life situation. Often a team approach is needed to make sure all psychiatric, medical, and social needs are met. Because personality disorders are long-standing, treatment may require months or years. Psychotherapy, also called talk therapy, is the main way to treat personality disorders. So medications, there are no medications specifically approved by the FDA to treat personality disorders, but there are some medications that can help with symptoms, and these include antidepressants, mood stabilizers, antipsychotic medications, and anti-anxiety medications. So psychotherapy, during psychotherapy with a mental health professional, the patient can learn about the condition and talk about their moods, feelings, thoughts, and behaviors. They can learn to cope with stress and manage the disorder. Psychotherapy can be provided in individual sessions. Group therapy is very effective when you're doing dialectical behavioral therapy, or sessions that include family and even friends. There are several types of psychotherapy. I won't get into all of them. And there's also social skills training, and then also family therapy to help support family that are dealing with a family member who has a personality disorder. So dialectical behavioral therapy. This began as a way to help manage crisis behavior, such as suicidal behavior or self-harm. It is the most recommended therapy for borderline personality disorder. It works with the concept of mindfulness or being present in the moment. This helps you to be aware of your emotions, moods, and behavior. You learn skills like how to tolerate negative emotions and how to communicate effectively. Cognitive behavioral therapy focuses on changing the basics of what you believe about yourself and others. And schema-focused therapy, it is similar to cognitive behavioral therapy in how it reframes negative thoughts about yourself into positive ones. So why? Why is it important to have this information about personality disorders within palliative care? And so I wanted to start with a short story, and then I was hoping that maybe in the chat box or joining in verbally, that maybe others could share stories or ideas about why this is important. So this is based on a true story, and I don't want to give too many details because of HIPAA, and so I'm gonna just kind of leave out some of the details. So this actually happened when I was working in palliative care. There was a woman who was admitted into the hospital for a non-life limiting condition. She was in her 50s, and otherwise she was healthy, just this kind of minor condition. But it did require subacute rehab, and she did go to subacute rehab for a while. And she was really unmotivated there, became deconditioned, stayed in bed, and developed these pressure ulcers. And she was actually back into the hospital again, readmitted with these pressure ulcers. And things just snowballed, and they really didn't need to snowball. It all just kind of stemmed from her being non-engaged in therapy, and also lying on the, just being immobile, and these pressure ulcers exasperated. And it ended up, she was in the hospital for a couple of months, and her care team they were perplexed. The hospitalist that saw her several times as they rotated, the dietitian, the physical therapy, they're saying, this woman is saying she wants to get better, but nothing about her is saying, about her behavior is it saying that she does, because she isn't eating the way she needs to eat for these wounds to heal. And she has really specific instruction on what she could do. And also she could easily get stronger by participating in physical therapy, but yet she says she wants it. The physical therapist comes and she refuses. And it's just so confusing. So palliative care gets involved, okay? And palliative care does a deep dive. They're trying to understand what might be missing here, what might be happening medically that we might be missing, or where's her family? No one's visiting. We're not getting any good psychosocial background here. We're just not figuring this out. It's not matching. So as we do this deeper dive, we talk with her, and at first we think, wow, maybe this is depression, because she doesn't have family and she doesn't really seem to care, not being engaged. Is this depression? Looking at that and sitting with her even more, it turns out it doesn't bother her that she doesn't have family. She does have siblings, and they invite her over for holidays, but she doesn't really go. And it doesn't bother her at all. And so we're learning more and more about her, and throughout her life, she's lived kind of this recluse life. And, a normal person would think, wow, that's really sad. Like, I feel bad. I want to help that. But what we find is it didn't bother her at all. And so it's a rare instance, but it kind of illuminates how understanding that sometimes people's personalities are just different than our own, and what we want to project onto them that may bother one person, it may not bother them. So what we found is that the criteria for schizoid personality disorder is they do not desire or enjoy close relationships, even with family members. They choose solitary jobs and activities. They take no pleasure in activities, or I should say few pleasure. They take pleasure in few activities, including sex. They have no close friends except for maybe first degree relatives. They have difficulty relating to others. They are indifferent to praise or criticism. And that's why the physical therapists were kind of perplexed that they're not really feeling this reaction that they would expect from someone that they're trying to motivate. And they are aloof and show little emotion. They might daydream and or create vivid fantasies of complex inner lives. So knowing this information, knowing that this person has a personality disorder that you create, you perceive and react to information a little bit or very differently than a normal. I don't like using the word normal, from someone without a personality disorder. And so, how does that feed our plan? How does that feed how we treat a client? How does that change how we triage things? And just kind of gonna leave it there for opening it up for conversation.
We probably have a lot of patients who have personality disorders that are undiagnosed. So we don't get in their chart, oh, this person has borderline. We don't get the warning label. And I wonder about if as this interdisciplinary team communication happens, and we might say, oh, we're seeing these similar features that map onto a certain diagnosis. If the diagnosis is really helpful for us, for the team members, to give us some sense of order in the midst of the disorder, the chaos. So if we collectively are saying, this patient seems to have features of borderline personality disorder, then maybe I won't be quite so surprised that one encounter I have with her is phenomenal. She's warm, she's engaged, and the next she hates my guts. Mm-hmm. And I'm thinking, what did I do wrong? Well, maybe I did something wrong, and maybe this is part of her struggle that I can just buckle up for and try to extend some grace and patience towards. So I don't know what you think about that.
I think that's beautifully said. It really is just understanding how they're seeing it from their paradigm. And also I was just thinking, it can really burn someone out if they walk out of the room and say, yay, I helped someone. They really liked me. I feel great that I was able to help, and this person got the information that they needed, and we were able to connect. And then to go in and have them kind of hate you and be angry at something you did. I mean, and then it can really hurt. Like, oh, what did I do? Then you're kind of thinking, what did I, what did I miss? Or you kind of question yourself, and you experience that over and over. That can burn you out. And so I think having an awareness that sometimes when things don't add up, I mean, we can't say everybody has a personality disorder. That's, we can't say that, but sometimes when things don't add up, and you're feeling it in your gut, and it can be a way to kind of help yourself so you don't burn out, and you're not beating yourself up either. It's just another tool to help understand people as you interact.
So if the general population has 10 to 13% personality disorder of some flavor,
I have to assume that we're seeing a much higher concentration.
I was going to say, when that number was given, the first thing that came to my head was that seems low to me. So thank you for that. And I think, and maybe, we talk a little bit about these personality disorders, but my guess is they're layered on with other mental health issues, anxiety, depression, and these types of things, which can really complicate matters even further. You see people coming in that are obviously depressed, and yet this doesn't seem to be the place to start treatment for that. And so we're just kind of kicking that can down the road. I mean, we can treat spot depression, spot anxiety, but the depression, nobody here wants to really get engaged with that in a short hospital stay.
I love someone who possibly has a personality disorder and would definitely benefit from palliative care. And wondering how the social work side of you, how would you direct family to connect the two? To
Okay,
connect, getting help for getting palliative care on board. And then, and maybe not citing the personality disorders that you suspect, but just how do you get them to palliative care? I can do that as a chaplain. I was good at doing it all the time, but as a family member, it's a little harder. So what would you have to say?
So what was the question? If a family member has a loved one? Or,
Yeah. How do you get your loved one to palliative care when you suspect that's what would address both the palliative care need and the personality disorder need?
well, how do you get someone to help a loved one with a personality disorder receive palliative care? Well, there's not an easy answer. The personality disorders, they're all unique within themselves. Let's take borderline personality disorder. That has a kind of a fear of abandonment or black and white thinking. How would you approach that? I believe that it's really difficult. I don't think there's a super easy answer on how. And even to go back, let's say to the example that I gave of this woman who had this personality disorder and wasn't wanting to receive any care. I don't think I have a good answer. I think this personality disorder, it's something that starts in adolescence, right? It's something that's been pervasive over time. So whether it's been, or adolescence or young adulthood, I should say, but it's not, like a serious illness is going to cause it, or it's something that you've had. And so the difficulties that you may, the family may be experiencing in the same moment, they've been experiencing their entire life. This same family might have been saying, how do I do X, Y, and Z so they stop going to jail? Or how do I do X, Y, and Z so they stop quitting their jobs and I don't have to keep paying their rent? Like, it feels stronger now because with palliative care, we know now that there's a complex medical condition, but this is something that they've been doing their entire life, these questions. And so it'd be how did they handle them, and I work with family members that say, gosh, my daughter, she can't stop breaking up with people and going through these volatile relationships, and I'm having to pick up the pieces all the time. How do I get them? And there really isn't an easy answer, because this is something that's been pervasive their whole life. If you can get them to the point, any client, I guess, but especially people with personality disorders, to the point where they're at their best equilibrium, if they're at their best state, if you can help them get there whatever that takes, whatever coping mechanism that is.
You know, what would you suggest for someone who is needing I mean, in my mind, if we could establish outpatient palliative care relationship, that would be helpful. Am I dreaming? How would I go about doing that?
To start an outpatient, what you mean with this family?
Yeah, to establish an outpatient palliative care situation.
Well, I guess
'Cause I think that's I think palliative care is the answer to all of the ills.
well, it is.
Yeah.
So no, just kidding. But I think that you have to get the patient to buy into it, obviously. And it is really difficult because that's kind of another topic I want to talk about one time is about boundaries. You know, I know in palliative care, you're used to, I would say, who all has hugged their client, you know, and with personality disorders, when it's not that they don't need love but it is, the treatment's different, and you want to watch the boundaries real close. So I think it is, you have to connect with the client, with the patient, and get them to buy in. And it's, you know, going to be to each individual client, but it could be that however you find a way to connect with them and get them to buy into the benefit, that's really it. Because even though, you know, the family, they've had this, we all know about the roles that we have with family members, that sometimes the client may or may not receive information well from a family member. They may or may not, they may receive it better from a professional. And if you can kind of illuminate the benefit to them to buy in, and it's a sensitive relationship. You want to give them all the love that you would give anyone else, but it's a whole different boundary because of the way they could perceive that love. They could perceive it differently because of the way they perceive information. So
Great points. Thank you.
Corinne, we've got at least 3 questions coming up. I want to turn it first to Lindsay, who has her hand raised.
Thank you. So your case, thanks for your information, Corinne. Your case brought up a couple of points for me. And I did have to step away for 1 quick minute, so I hope I'm not reiterating anything, but one of the things it brought up was the difficulties with goals of care conversations with patients in this population, because when we're inquiring about meaningful activities and meaningful relationships, and we're not finding those, you know, in a traditional, that would inform our goals of care and shape our recommendations. But this brings a big red flag to that for me, and how I can't even ask you how we navigate it because it's such a huge thing that we don't have time to cover. But I guess that was one of the points I wanted to bring out and was wondering a little bit about. And my second one was decisionality of a patient when they are having a personality disorder, and we're trying to decide if they're decisional to make medical decisions. Maybe they don't have a next of kin, or they're not close with family, and we're trying to navigate, can this person rationally make decisions that are consistent over time? And that's just those were the 2 areas that really stood out to me with your case. And yeah, I don't even know what question to ask you, because I don't think that can all be covered quickly, but if you have any insights that you popped into your mind.
The only thing I would say is good points. I don't there really isn't this cookie cut easy answer when it comes to this, because it's how they've been living their entire life. And it may or may not have, depending on, it probably has caused like chaos and broken bonds, throughout their life. And now you're here and it's the same behavior. You know, it's a touchy subject of when someone's decisional or not. It's kind of letting people, it's self-determination. It may not feel comfortable to us. It doesn't look like our personality, or maybe our, what our culture, what our norm, it may not look, but maybe to them, that's how they've been living. And we have to be comfortable with their chaos, even if it's not comfortable, if it's not normal to us. In some instances, it truly could be that their thought process is just that they can't receive this information and make a logical decision. So it's tricky.
Thank you.
Yeah. Corinne, Caitlin Kim asked, could you speak to whether there's a correlation between personality disorders and childhood trauma? If so, how might that inform our care?
So there has been, the answer to this is also we don't know. Because if you think about, you look, antisocial personality, a lot of murderers are, sorry to bring that up, but honest, and they may have come from really good families. We really can't figure out where this came from. It starts off as a kid with oppositional defiant. We don't know why. But with some disorders, there has been, especially borderline personality disorder, that sexual abuse, early significant trauma, there is some statistics to say that there's a high incidence of that, but it's not necessary. It's not concrete. It's not part of the diagnostic criteria that sometimes people don't have childhood trauma and they still have borderline personality disorder. So we think sometimes it may kind of fragment your psyche and the way you attach, and it could, but it's not concrete. It could happen either way. We really don't know.
Thanks, Corinne. Thanks for explaining the tool and answering all these questions. This was a great presentation, and I feel like we need 2 or 3 or 4 more of them. Well, I hope you all have a wonderful weekend. Thank you again, Corinne. Corinne, it was a great presentation. Bye
You're
now.
welcome. Thank you, guys. Happy to see you.
Likewise. Bye.
Bye-bye.